Akshita, we are live. You can start.
Okay, ma'am,
We
am I
are, okay.
audible? Am I audible, ma'am?
Yeah, you can speak little louder. You're audible.
Okay, sure, ma'am. Sure, fine. A very warm welcome to all the viewers who have joined us globally for this exclusive webinar by Sinodent. I would like to welcome Dr. James Gutman, sir, as per the Indian tradition with folded hands. Namaste, sir. I would
Namaste.
like Namaste, sir. I would like to express my gratitude to Dr. Anmol Bagaria, ma'am, founder and CEO of Sinodent and Team Sinodent for organizing this webinar. I am Akshita Gupta, UP State Scientific Head, and I am co-hosting this session with Dr. Misbah Kadri, Social Media Director, Sinodent. Now, I would like to introduce Sinodent. Sinodent, Global Healthcare for All. Sinodent brings to you Sinodent International and Sinodent India. Sinodent is a unique international digital healthcare platform, first time in the world. It is a revolutionary change brought in India by bringing a digital healthcare platform that will provide and enhance a good relationship between patients and doctors. It also enables a real time appointment scheduling system. Our goal is to create an easy and fast access to healthcare services. Sinodent is here to create precious and healthy smile on our patients' faces, always with minimum effort and maximum welfare. Sinodent International has brought for you research cell, blog section, educational programs for doctors to enhance their knowledge, skills and keep them updated regarding the advances and latest treatment developments. We are currently doing free webinars for students, dentists, senior practitioners from India as well as across the globe, which are different from the webinar era going on. We also design papers, mock tests, and send latest textbooks to budding students. We are trying to bring globally historic changes by uplifting our honorable profession more and more every day. Sinodent is also working for social welfare and humanity to enhance the quality of life by providing healthcare needs, health awareness, and free treatments. For today's webinar, I heartily welcome Dr. James L. Gutman, sir. The topic for today's live session is Challenges in Tooth Retention, the Crazy World of Resorption. It is my immense pleasure to be hosting Dr. James L. Gutman, sir. Dr. James L. Gutman, sir, DDS certified endodontist, PhD, FICD, FACD, FADI, FAAHD, FDSRCED, diplomat of the American Board of Endodontics, professor emeritus in the Endodontics and Restorative Sciences, Texas A&M University, College of Dentistry, Dallas, Texas. Presently, he is professor, chair, and postgraduate program director in the Department of Endodontics, Nova Southeastern University, College of Dental Medicine, Fort Lauderdale, Florida, USA. He is a diplomat of the American Board of Endodontics, past president of the American Association of Endodontists, and is the past president of the American Academy of History of Dentistry and the present editor of the Journal of History of Dentistry. He is the recipient of the I.B. Bender Award for Lifetime Educator Award and the Edgar D. Coolidge Award, the highest honor bestowed by the AAE. He has presented over 850 lectures, papers, and continuing education courses in the United States and 53 foreign countries. Additionally, he has authored and co-authored over 350 articles in both dental journals that address scientific, research, educational, and clinical topics, and 3 textbooks, and has taught full-time for over 30 years at 4 major universities. Now, I would request Sir to please start with this presentation.
Thank you very much. And it's a pleasure to be here and a pleasure to share a lot of these concepts with you. I'm going to be moving rather rapidly because I have a lot to share, but at the same time, I can't share everything. So I'm going to try to focus on what's important. And the audience will also begin to understand my role in the history of dentistry at the initial part of this presentation, because you're going to find out that we did not know a lot about resorption until very recently. And so I'm going to try to give you a little bit of a background so you can understand just exactly what has happened over the years. So I'm going to attempt share my screen here now. And okay, where is it? I had it up before. Okay, let me do it again. There we go. Now I got to get back onto the platform here. Why won't that share? Okay, come on. Can you see my presentation?
No, sir.
No, sir.
It's on my desktop. Now I don't know why it will not share.
Sir,
And
I
you-
have made you the co-host of the
Right,
presentation.
right. I understand that. Yeah, we're all set on that one. I'm just wondering if I can do this, if that will make it go. Just bear with me for a second. Sometimes there's always, can you see it now?
So you have to go to the Zoom app, and below on the taskbar there is a share screen option on the app itself, on the Zoom
Okay.
or the
There's a green
website.
icon.
Yeah, that I had done the share screen already, and that's why I was wondering why I didn't come up. Bear with me. That was the first thing I did was share screen, and I had the program up on my desktop. Okay, now let me get back onto this and see if I do share. Oh, there it is. Okay, it just wasn't coming up first. Okay, now we share. There we go.
Yes, sir.
Okay.
Now it's visible clearly.
Now you should be able to see it, and we're gonna
Yes, sir.
be cruise along here with these concepts. So bear with me as I move rather rapidly. Okay, are we good?
Yes, yes,
Okay,
sir.
great. Okay, wonderful. We're going to talk about the crazy world of resorption. As you can see on the picture on the right, resorption knows no bounds. When it comes to the two structure, it just will eat away and create all kinds of difficulties for us. And it's not always a simple resorption like apical. Oftentimes that's involved with other aspects. But when you see a young patient like this that has just undergone orthodontic treatment, it gets kind of scary. You've got to really figure out what has happened over a period of time. Let's take a look at what resorption is. Of course, it's a very important part of the normal physiological and pathological processes. It affects the hard tissue, soft tissue, foreign materials. There is physiological resorption, which we all undergo, and that's typical with the exfoliation of our primary teeth and the presence of the permanent teeth. Terminology is the newest terminology we have has been suggested by Shannon Patel from the British Dental Journal in 2018. We've seen various classifications of resorption over the years. This is the newest. It's not a bad one, but it helps to try to understand relative to the nature of the resorption and the location of it. The reality of tooth resorption, I think I'm going to show it right here. You can see what happens when you've got this type of situation where the tooth starts to get eaten away, even to the point of approaching the pulpal space and maybe not even entering the pulpal space. And I'm going to show you exactly what happens with that as we move along. Let's take a look at this case. Notice the molar, the premolar. The premolar had a crown preparation done, and it has 3 roots on it. And the referring dentist sent it to me and said, please evaluate for vitality, viability before I put the crown on. And I looked at it, we evaluated it, it was perfectly acceptable. All the teeth in the quadrant were perfectly acceptable. And then 30 days later, the patient came back. And when the patient came back 30 days later, my dental assistant came to me and said, are you sure this is the same patient? And I said, yes, that's the same patient. Well, let's take a look at the radiograph. And this is what the case looked like 30 days later. Completely unaware of the fact that the problem was not the premolar, the problem was the molar, but there was no way to determine just exactly the nature of the problem. And you can see how rapid the resorptive process can occur, which is really scary when you think about it.
Sir, I'm sorry to interrupt you. Sir, I'm sorry to interrupt you. Sir, you have not started your slide share of the presentation.
I haven't.
Yeah, presentation is visible, but slide share is not, so that all the slides are visible. We are on the first slide only.
Okay, only the first slide. Well, let me go back. Thanks for that guidance. Let me see if I can get this squared away here. Okay, it's got me sharing my screen right now.
So you can click on the slideshow. Slideshow, yes. From the start. Play from the start. Yes.
Okay. Yeah, I usually don't use that, but if that's what works, then great. Fantastic. Not a problem. Are we okay now?
No, sir. You have to click on the play from the current slide or start any way. It has not yet started.
It's interesting because I'm starting it on this end. Bring your shared window to the front. Now it says I'm screen sharing.
No, sir. This not the Zoom thing. From the PowerPoint itself.
Let me stop share and start over. See what happens. Okay.
Okay, sir.
Now you should have me on board, correct?
Yes, sir. I'm there.
Okay. Now let me escape here. It's coming. It's just such a big one. Okay, now let me get back to Zoom. I'm going to say it's to share screen. Okay.
Yes, sir.
I clicked on share screen.
So now kindly click on play from the start or current slide. Anyone will do. You can do the play from the current slide, the second option.
Second option, play from the current slide.
Play from the current slide. Yes, sir.
Okay, let's try that one. Again, I don't usually use those, but if that's what works, then that's what'll work.
Also, kindly double click on that.
Now it says sharing is paused. Bring your shared window to the front. I don't know why it.
Custom show you have set it. Can you click on the custom show?
I got to click off of this. I apologize to all their viewers.
Yes, and now it started. Now you can change the slide. It was started.
Okay, now.
Again, it has stopped.
Okay, what do you want me to do? It says I'm screen sharing.
No, sir. The screen sharing, your screen is visible. The slides, the PowerPoint presentation, all the slides should be visible, like one by one, whatever you're saying, it should be rotated accordingly. So that is not happening. We are on the first slide only, the challenges and to tension on the cover slide only.
What happens if I do this? It says sharing is paused. It keeps that note keeps coming up. Bring your shared window to the front. Is it sharing now?
So you have to go back again.
Okay, because it tells me that I'm sharing my screen.
Yes, so you are sharing the screen, but you have clicked on the video option, not the slide option.
Okay, let me do this then. Come on.
Also, you can click up, use the slideshow. There's an option, use slideshow.
That's what I'm trying to get to, but for some reason, there we go. Some reason it wasn't allowing me to get there.
Yes, and now it started. We are on the second slide. Again, it's
slide already. Okay. See, I don't see myself on the second slide. That's the interesting part about it. What happens if I go here? Is that the first slide? Can you see the first slide?
Yes, sir. The first slide is visible.
Okay, now let me try this. I'm going to do this, and I'm going to go to slideshow up on top of the screen. Let's see what we can get.
So you can click on just play from the custom slide. Then one by one the slides will be visible. The second option, play from the current slide.
You know, I've never had this problem. I've done this, I can't tell you how many times. This is usually, it goes very, very smoothly, but
So
who
now
knows?
it's fine. Now it's
Because
fine.
my computer is somewhat ruled by university policies. That's one of the problems we run into. Okay,
So it was fine earlier. Again, it is back.
okay, now. What happens if I press this? Play from the current slide.
Yes, 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 sir.
Is it there?
No, sir. Yes, so now it's fine. So now it's fine.
Okay, now let's see. Let me go to the second slide. Okay, let's see what happens. Okay.
Yeah, yeah. So now it's perfect. Now it's
Hey,
perfect.
look at that. Hey, we made it. Okay,
Yes.
great. I'm just going to move you guys over here to the side. Okay.
Yes, I'll spotlight you.
Pardon?
I'll spotlight you. Only you will be visible. We won't be visible.
Okay, no, that's fine. I don't need to be visible. What the heck? You can kick me off. That's fine. As you can see, and we're live now, correct? Everything's going fine?
Yes, and everything is visible.
Okay.
Yeah,
I'm
yes.
going to go to the third slide because we showed this one. This is what happens with resorption, with orthodontic tooth movement. And then we talked briefly, are we moving along okay? We talked about the different aspects of physiological resorption. Are we still doing good? We talked about resorption terminology, and that Shannon Patel had given us some new terminology based upon actual location of the resorptive process. And we talked about the reality of tooth resorption and how it can ravage a tooth in a very short period of time. As we can see from this case here, looking at the premolar initially and finding out 30 days later that we actually had the damage was being done on the molar tooth. And you can see how rapidly that the resorptive process can occur. Historically, was never referred to as resorption. It was referred to as absorption. For decades, it was called absorption, which is a very different process than resorption, which is resorption is being the organic process of, of taking structure and assimilating it or breaking it down, which occurs in living organisms. But our ancestors always thought in terms of the absorption process. And John Tomes was one of the first ones to bring this up back in the middle 1800s. And he used absorption. We actually used absorption well into the 1900s. He talked about it actually in 1859. He thought the process was in both primary and permanent teeth. There was often no indication of the presence of the disease until the patient actually had possibly a looseness of the tooth. He identified a patient of 50 years of age in which the tooth was eaten away on one side. And it actually went as far as the pulp, but then it stopped. And he saw that the pulp was encased in a thin tube of dentin, and that brought him to the realization 170 years ago or 160 years ago, that maybe the pulp has the power to actually resist the absorption process. Notice it's absorption and not resorption. Let's go one step farther. That's this type of case right here, where you see the resorptive process. You can still see the pulpal space that's present. The same way in this molar tooth. The same way in this cone beam CT, where you can see the resorptive process moving along the side of the canal space, but not invading the pulpal space. And this is what John Tomes thought about in 1859 already, that maybe the pulp has the power to control the resorptive process. And here's a perfect example of a case I did where I did actually excavate the resorptive process. And you can see this is the pulpal space, but this is the thin layer of dentin, predentin, which is over the pulp. But you can also see in the top where my arrow is, you can see an invasive part of the resorptive defect, which still is invading into the tooth structure. And this is what it might look like histologically, where even bone has moved in, the Haversian systems have moved into the tooth, but yet the dentin or the predentin that surrounds the pulp, as you can see here, has protected it and has prevented the invasion into this area. Now, will it ever invade? Yes. If you get bacterial invasion into this area to break down through the bacterial byproducts to break down the predentin, then yes, the resorptive process will invade the pulp and cause pulpal necrosis. Now, we had an article that was actually published back in the early 20s. Is it where we were talking about the fact, are we actually dealing, or in actually 1932, are we dealing with resorption or absorption? And historically, as I said, it was referred to as absorption. Rollins, who's the second picture up here on the left, 1868, he discussed absorption in response to tooth replantation and transplantation, which was very common in the 1800s. By the way, Rollins was also the creator of the first rotary endodontic handpiece, and he made his own endodontic files back in 1868. So for those of you that think that the rotary system had just started in the 1980s or 1990s or 2000, it's been around since the late 1800s. Black addressed absorption. I'm just showing you all these key people talked about absorption and didn't really quite understand what it was. Friedel and Sheff were the first ones to actually do experiments to talk about the role of the periodontal ligament in the absorption process. Tomes and Knoll, again, talked about the absorption, but recognized the same thing that Tomes did, that the pulp itself would tend to prevent invasion of the resorptive process. Buckley actually used both terms in 1910. Marshall alluded to resorption in 1926. And we have an individual, even in 1933, Sir Wilford Fish, who's actually an honorary member of the American Association of Endodontists. He still referred to the absorption process. So you can see historically, up until the mid 1900s, we didn't really know what we were dealing with. In fact, these are the kinds of drawings that we saw back in the beginning of the 1900s. They actually drew the resorptive things that they saw through the microscope, yet they couldn't define it the way we can. This is one of my pictures, which defines the histology of the resorptive process so much better. But you can see they knew exactly what they were dealing with. Multinucleated cells eating away at the tooth structure and creating problems. Ottolenghi in 1914 actually related more of the resorptive process to orthodontic tooth movement. Ketchum in the early or late 20s actually demonstrated the evidence of this in orthodontic tooth movement, which I'll show you here. He did some movement on the teeth, and he didn't think that he was getting any changes in the tooth structure until he took some different angled radiographs after the orthodontic bands were removed. And as you can see, not only were the anterior teeth blunted by the resorptive process, but the two molars on either side that were used as the anchor teeth for the orthodontic tooth movement, they also lost significant structure in their distal roots. So at that time, they began to focus. Resorption is really just an issue that we deal with relative to orthodontic tooth movement. Ketchum actually raised a number of studies, a number of questions, I should say, and these questions were expressed by Marshall in 1930. And it's all focused on orthodontics and resorption, or absorption as they called it. How many of these cases actually exhibit absorption? How does it relate to the duration and the type of orthodontic treatment? And then what other factors were involved? So you can see in the early 1900s, resorption and orthodontics were the two things that went together, and they didn't expand this concept of resorption much beyond the orthodontic phase. We saw a tremendous textbook that I have published in German by Bernard Gottlieb and Balint Orban. And you probably are very familiar with Orban. And they did extensive animal experiments on tissue changes during tooth movement. And these are some of the histological slides that they showed the evidence of the evidence of the resorptive process. And his textbook, or their textbook, went into great detail to try to focus on exactly what was happening. Now, remember, we're still talking orthodontic tooth movement and resorption. We're not talking any other types of etiologies that may impact on the resorptive process. Marshall, again, characterized it occurring very much so with the separation or tipping of crowns in the mesial distal direction, extrusion of teeth, tipping of molars, rotation of teeth, bodily labial movements. This is when they saw the bulk of the resorptive process. And any type of even bodily palatal movement per se of teeth. So they were really focused orthodontically, and which I think prevented them from seeing the fact that the resorptive process was something that was far greater than just dealing with orthodontics. He wrote a paper. I would suggest everyone get a hold of this if you can. It's really a classic paper in the classification, etiology, prognosis, and resorption and radicular. And notice he uses the term resorption in 1934. He has advanced from absorption to resorption. And this, I think, started to change the thought process for a lot of people. And what he came up with, he related it to malnutrition. In fact, he related it to the lack of vitamin A. And he did a lot of animal studies, and he looked at everything, and all these animals that were deficient in vitamin A were the ones that exhibited the resorptive process. And it had little to do with the diet or pressure on the teeth by the orthodontic bands, but had everything to do with the dietary process of the animal. He went on to, again, in that paper, and in fact, here's one of his pictures from 1934 where he classified or showed a resorptive bay. You can see how the osteoclastic cell, or I should say dentinoclastic cell, has moved into the dentin. And here's the same picture that I have from some of my own histology showing exactly the same thing. But Marshall also gave us something else we had not seen. And this is what started to raise the awareness to the resorptive process. And that was, he showed apical resorption due to incomplete root canal treatment. As you can see by the picture right here, how the roots have actually been resorbed, and you can see the poor or incomplete root canal procedures that have been done. So all of a sudden now we're moving out of orthodontics into maybe the resorptive process occurs for other reasons, which was extremely important to understand. Let's not worry about that. Kronfeld is the one that possibly made the biggest input into the expansion of the resorptive process back in 1933. First of all, he talked about it as the absorbent organ, which we would see when teeth erupt, permanent teeth into primary teeth. So he did a lot of experiments looking at this aspect of it and demonstrated the eating away or the resorption of the tooth structure. But then he went ahead and he identified resorption occurring in all these different areas, from occlusal trauma and idiopathic, deciduous teeth, the role of the pulp, impacted teeth, radiographic assessments occurring in pulpless teeth, replanted teeth, tumors, orthodontia, cemental repair. He is the one that expanded our minds tremendously in the area of resorption back in 1933. And he was a rising star in the research area. And we're sorry that he didn't stay with us in 1939, because he actually had developed some severe mental disease. He took his own life, and which was a shame, because he was a star, and he would have, I think, impacted greatly on dentistry as we know it today. But he talked a lot about this apical resorption, especially when it comes to endodontics and infection. Now, all of a sudden, we're getting away from orthodontics and talking more about endodontia, and also in replanting of teeth and things of that nature. So it's very important. And as you can see, that invasive type of resorptive process on that histology that you can see right there, and these types of resorptive situations that we see in today's oral cavity. And as you can see, I've got histology which shows exactly the same thing he showed many, many years ago. Now, real fast, what happened with resorption? We didn't recognize it even in 1928. Even Grossman didn't recognize it in 1940 and beyond. Coolidge, one of our big leaders, touched on it briefly. Healy, Summer, and Ostrander and Crowley, who wrote some of the first textbooks, never addressed resorption. John Engel addressed it only briefly. So we can see we've got a bunch of people here that we looked at as stalwarts, and for some reason, the concept of resorption did not make it to the forefront. It did not really rise to the focus and the importance that it should have until approximately 1973, 74, 75, when people like Al Frank addressed resorption in his publication and presentation, and Noah Shivian wrote a chapter on root resorption in 1976. That was basically the beginning of the endodontist understanding the resorptive process and what we were dealing with. And that wasn't too long ago. 1976, what do you got, 24, 46 years ago, even though we knew about resorption well over 100 years. What's our present understanding? Well, there's so many things: the biological processes, the terminology, the radiographic considerations, treatment, outcomes, challenges. And as you can see by just looking across the section here, for all the different aspects of resorption that we have, from the tissue destruction to the invasion with bone to the root restriction. We're not going to go into each one of these areas because this could be a whole day course in and of itself, but we're going to touch upon some of the key areas. First of all, every one of you in the audience today has this type of process going on in their teeth. What you're seeing is surface resorption, surface repair, and sometimes it'll go a little bit deeper into the dentin, as you see on the far right. However, this is not a problem unless you have a pulp which is undergoing inflammation or necrosis, in which the bacteria and their products can communicate through the dentinal tubules. So in essence, what we've got is surface resorption, inflammatory resorption, and replacement resorption. But that surface resorption is not an issue, it's not a problem. This is the big problem, and that is the presence of bacteria. If the bacteria somehow enter into the resorptive process via a periodontal pocket or via necrotic pulp, this is when the resorptive process runs wild, like a wildfire, and starts to eat away at the tooth structure. So we're just going to cruise along here rapidly. As you can see in some of these, it's going to go a little bit deeper. It's going to cause other problems. It's going to eat away at tooth structure, where we start out with a tooth like this and end up with the tooth like this over a period of time. That's because of the various other influences and etiological factors that will come into the resorptive process. And at times we will get the ingrowth of the bone, as you can see the Haversian system actually growing into the dentin and creating the type of replacement resorption, or to the point of ankylosis of the tooth structure, which we all are aware of. Now, we generally focus on the external inflammatory resorption, which affects the root surface for many different reasons. It's mainly injury to the tooth structure. The dentinal tubules are exposed, communication with the internal aspects, the pulp, especially if the pulp is undergoing necrosis, inflammation of the periodontal tissues and things of that nature. And it can progress to the point where we actually lose the tooth completely. And orthodontic tooth movement, certainly. We can't dismiss that. It still plays a major, major role in the whole resorptive process that we're dealing with. We see resorption at very different levels. We've seen people that have written more, and like I mentioned, Patel earlier, and Jeff Hithersay and Martin Trope. We see it in chronic periapical periodontitis. We see it through pressure changes. We see it through orthodontic tooth movement. We see it with impacted teeth and tumors. Oftentimes, these teeth will be non-responsive to sensibility testing. We may have an infected root canal system, but the patient may never know about it until they come and they find that the tooth is somewhat loose, or they develop signs or symptoms. The symptoms of an apical periodontitis that's tender to percussion. And if we don't have those things, the resorption can continue, and the patient will never know that they have these difficulties, or if they develop an abscess. We also see the various radiographic changes that can occur. Now that we have our cone beam available to us, we can begin to see some of these changes, as you can see on the lower right-hand side, the kind of loss of tooth structure that will occur. And we always don't see it on periapical radiographs. And that's why when it's ever suspected that resorption may play a role, it certainly behooves the dentist to consider a cone beam CT to try to pick up these aspects. And the other problem is, if it occurs on the buccal or lingual wall, or buccal or palatal wall of a tooth, we may not pick it up until approximately 40% of the tooth is resorbed. If it occurs on the proximal aspect of the root, we'll see it right away. And so that's what we want to look for. So if you don't see it, it doesn't mean it's not there. That's something to keep in mind. Trauma is one of the biggest things. You can see in this case, for example, we had more of a force from an impacted canine, but you can see through a little patience over a period of time and not necessarily rushing to take the tooth out. The tooth could still be involved in orthodontic tooth movement, and the tooth can get healing, and we don't always have to remove these teeth. So there's a caution here to maybe wait and watch on a lot of these things that you can get favorable healing. One of the biggest challenges we face as endodontists is that chronic apical periodontitis with apical resorption, as you can see. What do you do with your working length? How do you manage the control of your files? You manage the control of your filling materials? Will you get healing? Or are these teeth destined to be extracted? The tooth on the bottom, the very bottom picture, you can see that tooth was actually used for orthodontic purposes, and you can see the loss of the distal root structure. You can see the calcifications that occurred. The pulp is undergoing degeneration. Yet now we have to deal with this endodontically if we're going to keep these teeth. And the challenges that we face are, where do we go with our instruments? How can we disinfect? How can we get it sealed? How can we control it? And if we can, guess what? We can stop the resorptive process very, very nicely. But here are the challenges. The challenges are the irregular apex. You can see the top photo there on the right-hand side, the irregular eating away. The middle photo shows an SEM of what this looks like. And the bottom photo shows actually how the cell is are entering into the tooth structure and eating away at the dentin. And you can see the peritubular dentin. You can see the dentinal tubules, which are the last things to be broken down by that little cell that you can see here by my arrow, that you're showing this type of clastic activity. By the way, as I mentioned earlier, when you're talking a tooth structure, you're talking an odontoclast. When you're talking bone, you're talking an osteoclast. They both function in a very similar manner. We ought to focus on this inflammatory process, which can occur after injury, especially after trauma. And as you can see by Abbott's categorization here, the least likelihood of having the resorption is going to occur with concussion or subluxation. You can almost plan on having the resorptive process when you're dealing with intrusion or avulsion. So we have to place a very careful evaluation of these kinds of teeth. And we have to have treatment strategies in the area of prevention, preventing trauma. How do we do that? We do that with mouth guards and things of that nature. We want to minimize any damage. We may have to use pharmacological manipulation during the process, such as calcium hydroxide or even steroids, depending upon what we're dealing with. Education of the patient, mouth guards, minimizing additional damage, tooth repositioning, replanting, how we manage it. You can replant a tooth. You can do intentional replantation. You can do auto transplantation, but you've got to do it within a 5 to 7 minute period of time. You have to be very efficient. We are doing a lot of intentional replantation and auto transplantation here at the college in Florida, but we have anywhere from a 3 to 4 member team, and everyone has responsibilities so that when a tooth comes out or is being moved to another socket, this is all done within 5 minutes. And we manage it very, very rapidly. And we are not seeing any type of resorptive process. So prevention can occur with these types of things. Minimizing the oral drying time. If we have to, we keep the tooth in appropriate storage media. For example, once in a while, we might have to put it into a Hank's balanced salt solution from the time we extract it until the time we can actually get it repositioned, but that's rare. We usually do it very, very rapidly. We might use a functional splint. We might not use a splint. It just depends. It depends on how well the tooth is repositioned in the socket. Trauma, pharmacological, this is where we might use antibiotics. The tetracyclines have shown to be somewhat effective. The doxycycline, it inhibits the osteoclastic activity and the collagenase activity. Virawan Salim out of Malaysia went ahead and actually did and it published a paper on tetracycline versus amoxicillin and recommended that the use of that with avulsion procedures and had less inflammatory responses. So we can see these types of processes if we manage them through some methods like pharmacological, where we can use steroids to alter the recruitment of the osteoclastic activity over a period of time, and possibly the use of corticosteroid antibiotic mixtures to reduce inflammation, infection, such as letter mix. I cannot get letter mix in the United States. It's not for sale here. I have brought it back into the United States from Australia as contraband at times, I'll admit that, and I've used it. But we find that we can work around that. We don't necessarily need it to be able to control some of these things, to be able to control that resorptive process. Now, that histological slide I just showed you, that's a slide you're not going to see very often. That is a true osteoclast, which represents every histological parameter that you can think of when you think in terms of what an osteoclast looks like. Multinucleated giant cell, you can see the brush border, you can see where there are actually attachments on both sides of the cell, which attach it to the bone. And during the process, there's an exchange of minerals to a point where once a certain level of mineral reduction is satisfied, this cell will actually release its attachment and pull away from the bone and possibly stop the resorptive process or move to another part of the bone and continue. And the same thing happens internally with teeth. I won't worry about that. We also have if we can prevent a pulpal space infection, we can see teeth that have undergone trauma. If we can maintain their vitality, we can get a revascularization. We're not really sure what revascularization really means yet, other than the regrowth of vascular or angiogenic systems, cell populations into the tooth. The idea is to keep the pulp healthy. If we can do that, we can prevent not only necrosis of the pulp, but also the resorptive process. And so it's extremely important to keep that in mind when we manage these teeth that are undergoing trauma. So we can prevent the root canal infection if it should be out where we can't get the tooth back in time. We want to do the root canal treatment in a short period of time. We prefer to do it in one visit when possible. The other big challenge is serious traumatic injuries can be very difficult. When we shape and clean, we usually use calcium hydroxide. Now, the long-term use may be up to 30 days. The big problem is we have a number of publications which say longer than 30 days might result in the weakening of the tooth structure. That is generally more due to cases in which the tooth is open apex, immature root formation, and you have thin root walls. The tooth already is structurally compromised, so that may not be the case. But we have a lot of conflicting literature out there which says, on the one hand, long-term use will weaken the tooth structure, and others will say, no, it really doesn't. So this is something that has to be resolved, and it's a great area for research yet. If we can obturate the root canal system as soon as possible, that would be great. And make sure that we have good periodontal health. That's the key thing. So if we can eliminate the pulpal infection through good management of the root canal system, with the calcium hydroxide. Also, keep in mind, what kind of calcium hydroxide are you using? If you're using straight calcium hydroxide powder and liquid, it's going to run at around 11.5 to 12.5 pH. And that can cause a lot of calcific scarring, but it can also bring about a cell response. If you're using the commercial calcium hydroxide, the injectable, that's going to be a pH of about 10 to maybe 10.5. It may not be quite as effective for what we're trying to achieve, trying to arrest the resorptive process. So we're looking at the alkalinity around the dental tubules. We're looking at antibacterial agents. We want to encourage hard tissue to form. By the way, that calcium hydroxide will also help to alter changes in the vascular system, will help in recruitment of cell populations in pluripotential cells that are located in the periapical tissues. So, and in many times, we might have to change the medicament. I think we're getting away from that. I think what we're doing is using calcium hydroxide for a short period of time and then following through with one visit type of MTA placement apically and finishing up in these types of cases. Here's a case that was done by George Bogan and Sergio Cutler, advocated the MTA used in these cases, that the MTA would actually serve to provide the alkaline pH and control the odontoclastic activity. And it's a promising option. And we've also seen the study paper done by, published a few years ago by Dave Witherspoon and John Regan, in which they found that doing one visit apexification cases with MTA yielded about a 93% success rate, where the 2-visit ones with calcium hydroxide and then followed with MTA actually were down to about 90 or 91% success. So it appears as though maybe the 1 visit might actually be better. Then we've got this classic activity that we see on that external replacement resorption. We can't get away from it. The bone is created, it invades the tooth. It's usually associated with some more severe, as Abbott pointed out in that listing before, such as intrusive avulsion. By the way, the intrusive luxation is one of the most damaging, even more so than the avulsion. The intrusive luxation really does more of a crushing of the tissue and damaging of the cells. And that the chances of retaining a pulp after an intrusive luxation is only about 4%. Where with avulsion, and if the apex hasn't fully formed, you've got a much better chance to actually maintain pulpal status. You get diffuse damage on the root surface, the ripping away of the cementum, which then brings about a greater resorptive process. And then we get that abnormal attachments. Some of the things you can do clinically to see whether or not you do have this type of invasion. Most of the time, these teeth are symptom-free. They'll give even normal responsive sensibility testing. But what you want to look for is, does the tooth have a high pitch or metallic sound to percussion? And when I do that, I actually make sure that the room is very quiet, that my operatory is very quiet. And I ask the patient to listen very carefully to see if they can see or hear a difference, I should say, in the sound of their teeth when I tap on them, when I percuss. And it's amazing how the patient will see it. And their eyes will open up and they'll raise their hand and say, yes, I recognize that. And then I can explain to them what's happening as far as the replacement resorption or the ankylosis that may be occurring. And the tooth may appear to be infraoccluded. So these are some things you can work with your patient to let them understand and educate them as to what the process might be. We also can see a lot of destruction of tooth structure. And the cone beam is going to help give us some details on that. We can have complete loss of the tooth structure, as we saw earlier. There may or may not be a radiolucency. It just may be eating away of the tooth structure. And we have that, what we call the moth-eaten appearance that we see in these types of teeth. Sometimes it's a little bit more aggressive. I look at this case, and it was from Shannon Patel's paper. More often than not, you cannot arrest that case. You could try. It might, if you were to remove that filling and maybe re-clean and fill short where the resorption stops, you might be able to do something with it, but routinely not. Eventually, you get complete resorption. Usually occurs in younger patients, rapid progression, which is a problem with younger patients because you have a disruption in arch formation, things of that nature. So to intervene as soon as possible is very important. Now, with older patients, it's usually a slow progression, and oftentimes we don't see it until it's way down the line. And then by that time, it may be too far. But more often than not, too, we watch these cases. In fact, we have a couple of them. I'll show you one later. We're just going to watch, and we're not going to do anything on until we see what's going to happen over time. Following options may be considered with that external replacement. You can accept the position, restore the incisal level with the composite, and monitor the tooth. You can do an auto transplantation, but that might create a problem in removal because you might be taking excess bone away in the process. We can do surgical repositioning as long as the tooth is not fully ankylosed and it's just a minor replacement resorption. We can actually reposition the tooth surgically and then establish it at a different level. Or we can just go right to extraction. But keep in mind, if it's a younger patient, we're not going to be putting implants into these patients at a young age because of the growth and development that still has to occur. We do a lot of decoronation. Right now, we probably have anywhere from 6 to 10 patients right now. We're doing a tremendous amount of decoronation, especially in the patients that have had bisphosphonate activities over a period of time, and we cannot afford any osteoradionecrosis, especially those that have undergone radiation therapy. So we're working closely with the hospital and doing a tremendous amount of decoronation. We had one yesterday where one of my residents actually did the root canal treatment decoronation on number 2-8. And we have as many as 14 teeth in some of our patients where we do this. So we can do a surgical repositioning where you actually lift the tooth and bring it out and then reestablish it in a different scenario. This works if done carefully, done with minimal trauma. Tooth extracted, not fully extracted, just bring it up out of the socket a little bit and then reposition it and stabilize it with some orthodontic bands and get on with it. Correct the vertical and horizontal discrepancies. It can be done very nicely. This has been done actually for years in Scandinavia. Functionally, go ahead and splint the tooth. We talked about the decoronation. We preserve. You got indications. You might want to do it with an implant retained prosthesis, or pathological fractures might be evident. You definitely want to preserve the alveolar ridge, and definitely when we have the medically compromised patients, as I mentioned, we want to consider possibly the decoronation. The aesthetics may be compromised. We have to go in on these cases, do the root canal treatment. We generally put some type of filling in the coronal aspect. It could be a Jerry store type of a composite. It might even be an MTA. And then we go ahead and close these procedures, and we establish good alveolar ridge. And over a time, that tooth actually might undergo complete resorption, or it may not, but it'll still serve as a nice bed for doing an implant if we want to. You can see what can happen over a period of time. Felipe did a study in dental traumatology and demonstrated the preservation of bone. And that's the key thing. If we can preserve the bone at the extraction site, I think it's a phenomenal service that we can provide the patient when we have these resorptive defects. Cervical resorption is a real nasty one. It's the same etiology. It just has a different location as Patel has pointed out. We're talking about location now. The non-mineralized pre-cementum has been disrupted. Ultimately, also, we get disruption actually of the, because of bacterial influence, we get disruption of the predentin, and we get exposure right into the dentin and into the tooth structure. And there are various phases where it gets initiated, it progresses, and then it may undergo repair, but most of the time it doesn't do that. The factors that bring about this were brought forth by Hithersay, trauma being number one, intracorneal bleaching, surgery, orthodontics. And he pointed this out in all the factors that he took a look at, with orthodontics being the most common, following by trauma. And these are the categories that he's put these teeth into. You can see the class 1, 2, 3, and 4, and the extensiveness of the resorptive process. More often than not, you can manage class 1 and 2. You can try number 3. Number 4 is very difficult, and you may just have to end up resorting to having the tooth removed or waiting until it undergoes complete resorption, the apical root resorption. I'm not going to go into great detail. I think you can see the picture actually tells you exactly what you're dealing with in these types of cases. Here's a case where you can see, and we had a case like this just the other day. Exactly, and we're going to watch this right now. We're going to see what happens, because we know if we go in here right now, we might do more to destroy the tooth structure, and the patient's symptom free, and there's no probings. If there's probings, then we have to be concerned because of the bacterial influence into the resorptive process. These are the kinds of cases I get to deal with, and you can see that invasive resorption. I have actually found these to occur quite frequently in mandibular canines and mandibular premolars following orthodontic treatment, where I get this invasive type of cervical resorption, which just eats away at the tooth structure. Makes it very difficult. And again, Patel went into this whole different process of where it would be located at the cemento-enamel junction, or extending into the coronal third, or to the apical part of the root. I mean, you can read this, and I think I would encourage everyone to go ahead and get this paper and do read it and understand that we're basing it on location now more than anything else, and how we try to manage these cases. For example, here's a case that's just occurring in the cervical area. You can see it right here where my arrow is pointing, and we have the initial aspect of it. And more often than not, what we try to do is we try to eliminate that resorptive process. As long as there's still a surface defect and there's bleeding there, we try to eliminate it by cleaning it out the same way we might do a cavity preparation. And we use a 90% trichloroacetic acid. And we clean out the resorptive tissues in these types of areas. Even when it gets deeper, such as this, we can go and reflect the tissue a little bit and get that pink spot in the tooth. And we can go ahead and clean those areas out and use the trichloroacetic acid to eliminate the resorptive tissue. When we get to this type or this level, this makes it a little bit more difficult because of the destruction and the advancing into the pulpal space area. More often than not, these may end up to be extracted. Now, I don't have enough time to show you today, but we've actually managed a number of these teeth and have kept them in the mouth for a number of years, but sooner or later, the patient has to understand they're probably going to lose these teeth. And that's that class 3. They might see a pink spot. They might have that irregularity, as you can see. Radiographic features is that moth-eaten appearance, which is moved into the tooth structure. And there's usually a radiographic line of demarcation, how far it's gone. Crustal bone is usually unchanged. You have to do some soft tissue management in this case in order to be able to do something. And if the root is long enough and wide enough, you could consider a root extrusion and also management of the resorptive process. When you get to this level, the class 4, most of the time what we end up doing with these, we watch them. We don't do anything to them. There's not much you can. And more often than not, the patient may come back with the crown in their hands where the crown is broken off, or they'll come back with a swelling abscess. And we're really not able to manage these cases to any great extent. So if they're symptom-free, we just watch them. And one of the ways to take a look at these is to use different angle radiographs, which Trope has showed, which will kind of give us a location where the resorption might be located. And because these are easily misdiagnosed, especially if the resorptive process is located on the buccal or palatal aspect of the teeth. I say palatal because most of the time we see it in the maxillary anterior teeth, not so much the mandibular. But to do that type of differentiation, you have to be able to see exactly what you're dealing with. And as I mentioned earlier, and Andresen has shown us, and until you get about 40% of the loss of the mineral per unit volume in that buccal or palatal surface, you're not going to really see the resorptive defect. If it's on the proximal, you will see it. So we want to get rid of the resorptive tissue. We want to be able to seal a defect if possible, do some repair. Sometimes we have to do the root canal treatment. Sometimes internal repairs as opposed to external, whatever the case might be, or in some cases we have to extract. I'm just going to run through these rapidly. This external repair, another use of the trichloroacetic acid, retraction of the tissue and then repair and place with a composite. Sometimes combination of doing the root canal treatment along with the repair is necessary. This is going to be more of a class 3. If you catch it early, and oftentimes you don't pick this up on a regular basis unless the patient says, I see something, a different color in my tooth, or I take my fingernail and I can catch an area in my tooth, or my toothbrush gets caught up by the gingival tissues. It can occur also in molar teeth. It doesn't have to be limited to anterior teeth. Using internal repair procedures, in some cases, we can do the root canal treatment or even an intentional replantation, as you see here, where the tooth is repaired. You can see the defect that's present and then a replacement. And in some cases, you're going to have to go automatically to the implant. You're not going to be able to avoid it. When you have this type of surface resorption, it's non-infective, it's transient. Oftentimes, for example, it's usually caused by orthodontic tooth movement. You stop the orthodontic tooth movement or alter it, and guess what? Things heal. You get the reformation of a lamina dura, and the teeth are usually fairly stable. If it's impactions or tumors or cysts, then we have another problem, because sometimes you may lose the tooth based upon the surgical procedure that has to be done. Most of the time, though, it'll stop. If you take away the pressure from whatever the source may be, it will stop. And the area that was resorbed will return, and you'll get cemental repair, which is great. Having the cone beam is beautiful. We didn't have this years ago, but having it now really helps us understand the nature of what our problems might be. So we have to take a look at from all aspects, from the clinical, the subclinical, the radiographic, do our cone beams, see exactly what we're dealing with, and don't be so sure to run and say, we've got to extract this tooth. And that's a problem today. And I hate to say it, it's a problem I'm dealing with in my own dental college, where all they want to do is extract the teeth and put implants in immediately. And I've been fighting with them to try to retain a lot of these teeth whenever possible. Even these short-rooted teeth, if there's no mobility, if it's all physiological mobility, leave them alone. Advise the patient and be able to maintain the area. We can see these types of things. I'm not going to spend a lot of time on this. You can see how we can get healing. Repair can occur. It's the pressure of orthodontic tooth movement, which oftentimes will do it, or impacted tumor, as we mentioned. Now, one of the last things I want to talk about is transient apical breakdown. This was brought to us by Francis Andresen. That's me with Francis a few years ago in South America. And it's a unique thing that it's a temporary resorption of the bone around the root apex and the dentin, and eats away, and it can repair itself. It's usually only found in fully formed roots. It resolves usually within 12 months. And it's not necessarily a need to do root canal treatment, especially if the pulp is responding favorably. We see a lot of these types of cases. One thing that you probably have never seen is her publication, which is quite interesting when you look at this, because she used the picture from one of the movies, but that's her publication, and I actually have it in front of me. It was a special publication which really focused on this transient apical type of breakdown. The clinical features: discoloration, hemorrhage, delayed response, but don't be so eager and ready to go ahead and do root canal treatment. You can follow these cases over a period of time and you can get healing. It's amazing. And this is where you really have to be a diagnostician and spend the time to do what's necessary. And don't be so ready to jump in, especially when the patient is symptom-free. I can't spend a lot of time on this because I know my time is just about up and I don't want to forestall this. Real fast with internal resorption, you can see it. We've all seen it. It can occur from various reasons. Oftentimes, we're going to have to go ahead and manage it by removing the tissue, altering the odontoclastic activity in the tooth structure. And it means cleaning out a lot of good irrigation, using of chemicals to stop the resorptive process, unless there's a lesion already, and then it's really stopped. Most of these teeth are symptom-free. We don't even know about it until you do a radiographic survey, unless we see some type of discoloration. You see a tooth like this is very common with something that's detected radiographically. These are easily to manage. You can usually see the outline of the root wall should not be traceable through the resorptive defect, which tells you have an internal resorptive defect. These are some cases. You can see how that it's going to appear. And sometimes we'll go ahead and we'll do the root canal treatment. That doesn't mean we're going to be able to save the tooth, but we try in most of these cases. Sometimes we get this type of crazy internal inflammatory resorption, which is hard to distinguish. And so we have to go through a diagnostic procedure. And it doesn't penetrate. The pulp is actually doing fine. There's no obvious penetration per se, and doing a micro CT scan, or I should say cone beam, will help us to understand exactly what we're dealing with. Again, the color changes may be there, wherever the case might be. And again, manage these straightforward using calcium hydroxide in the meantime, because it helps to break down the resorptive tissue and to stop the clastic cells. And then the root canal treatment. We're just about done. We'll finish up. Do a lot of good irrigation, a lot of chemical management with the sodium hypochlorite, chlorhexidine, ultrasonic, things of that nature, which is very important. And then follow through with calcium hydroxide. And the calcium hydroxide will also tell us whether or not we have a perforation outside the root. We can see the resorptive defect, get the tissue cleaned out. I know some of this doesn't make sense to you, but I think you all run into this thing. I only wish I had more time to be able to go after these things. Just to show you a couple of cases real faster that were done by various authors managing internal resorption. And it can be managed. It doesn't mean you have to extract these teeth. Using the cone beam effectively. Sometimes we do surgery to try to do it. And sometimes we even get a replacement resorption internally. This is a rare occurrence though. But you're still going to go ahead and treat it the same way. You're going to do the root canal procedure, provided there's symptomology. If there's no symptoms, leave it alone. Don't do a thing with it. I think one of the things with resorption that we all have to learn is when to treat and when not to treat. I think that's really important. Rapid picture, there I am in the middle with Jeff Hithersay on the right-hand side and a famous endodontist, Steve Cohen, on the left-hand side. Jeff and I have been friends for years, but he has given us a tremendous input into the whole resorptive process. And anything you can read by Jeff Hithersay, I would encourage you to do so. Some of the challenging questions, which I'll leave you with. What type of resorption is present? You got to figure that out somehow, some way. Will it be self-limiting? Is it transient? Does it require management? Now, one thing very, very important to keep in mind, if I leave you with nothing else today, you are never going to be treating resorption. We don't treat resorption. We manage it. We remove the etiology. You are doing nothing to actually treat resorption. Just keep that in mind. People say, I'm going to treat the resorptive. No, you're not. You're going to remove the tissue, you're going to remove the etiology, and you're going to create an environment for healing. So it's pure management. It's not treatment. Is it progressive? Will there be a favorable response? If managed, what's the short and long-term prognosis? When is extraction and prosthetic replacement indicated? These are the kinds of questions you have to ask yourself. And this is the case I had to deal with yesterday. What to do with this case? I'm only showing you one small cone beam section here, but look at the massive amount of resorption. This patient is symptom-free, patient is functional, patient likes the tooth, and we're just going to wait and watch. And we've told her, chances are we're not going to be able to do anything with this tooth at all. So you can see the crazy world of resorption is all over the place. It expands, it enters in, and eats away tooth structure and creates a real challenge for all of us. And that challenge you have to deal with, I have to deal with. But if you go back on some of those questions, it's very, very important that you deal with those types of things to try to determine what you have. Now, I'm throwing this up as a last minute type of thing because you can see my email there. And if you have questions, concerns, or looking for a certain article or something, send me an email, ask me. I'll be more than happy to try to communicate with you and give you input so that we can all work together to try to retain as many teeth as possible. And the bottom line is that we treat the patient the proper way. With that, I thank you very much for the chance to rapidly, sorry to say, share this with you. I could have shared a lot more, but this is a good overview of the resorptive process and the crazy world that we have to deal with. Thanks very much. I do appreciate it. You take care, and I hope to be able to interact with many of you people in India. I should be there later this year, provided all transportation is going to be available for me to enter in. I've had my COVID vaccinations. I have high levels of antibodies, so that shouldn't be a problem. So we'll just have to wait and see what happens. So we're back at our Zoom. We're back with our personnel here, and I'm going to stop sharing, and I hope I was able to shed some light on the resorptive process to our participants.
Sir, we have a lot of questions during the session, but you almost answered most of the question. But still, we have a few questions for you. If you permit, shall
Sure.
I proceed?
Go ahead.
Okay, sir. The first question is, what is the best way for the management of a perforating internal inflammatory root resorption in the anterior teeth of the maxilla?
Okay, probably the best is going to be to debride the root canal system, good irrigation, but be careful because it's perforating, and then use something like Biodentin or a non-staining MTA. There's a number of new non-staining MTAs available that you can pack into that area, the resorbed area. Now, you might want to fill the apical portion with gutta percha and a bioceramic sealer, but then fill the resorptive area and the area that's perforated. You compact an MTA or a Biodentin into that area. And then the most important thing, get a good sealed coronal restoration on the tooth.
Sir, the next question is, what precautions are to be taken in endo treatment if the patient is suffering from considerable root resorption?
That's a good question because we've got a young lady who's 14 years of age right now and has resorption in every one of her teeth, and we don't know what to do. We do not know what to do. We really don't. If they have a lot of resorption, all you can do is take it tooth by tooth and take a look at what are the ones that most likely you can do something about, depending upon the nature of the resorption. Is it internal? Is it external? Is it invasive? Is the root being eaten away? And then try to determine the etiology. What possibly caused the problem? The biggest challenge we got is when we have the idiopathic situation. We don't know what caused the problem. I can tell you what we think it is. And with this one young patient we have, we think it's a genetic defect. Why all of a sudden would a 14-year-old evidence resorption in every one of her teeth, not having any orthodontics, having no decay, having no trauma? What would cause? It has to be genetically driven. We don't know how to deal with it. So we're doing the best with her, just trying to keep her pain-free.
So the next question we have is, what is the preferred treatment plan if a young patient has a root resorption to a great extent?
I would, again, here, clean the canal system as best you can, if you have to, if there are symptoms. Clean it and pack MTA, even if it's a half of a root that's left. We've got a number of cases where we've packed it down to the half of the root, and all of a sudden the lamina dura starts to form over the end of the root, and the tooth becomes stable. Now, if it doesn't, it'll just go ahead and be eaten away, and the patient has to know that that's a possibility. You can't do too much about it. We see a lot of it here in Florida. I saw a lot of it when I was in Texas too. It seems to be getting more and more. I don't know. It's almost like a disease, but we have to learn how to deal with it. And I think the biggest way are two things. First of all, to be able to not jump in and just say, let's take the tooth out right away. Secondly, to try to determine what caused the problem. And third, how can we potentially manage that problem?
So the last question we have is, what is the best way to manage internal resorption?
Remove the pulp. Now, internal resorption, if there's a lesion at the end of the root, the internal resorption will not go any farther because the pulp is dead. Okay? If there's no lesion and you've got internal resorption, take the pulp out. Stop the internal resorption. A lot of good irrigation to kill the odontoclastic cells in there, and good root canal treatment.
So thank you, sir, for such an informative lecture. And I would also like to thank Dr. Anmol ma'am for organizing this event. And at the end of the session, I would like Dr. Anmol Bagaria ma'am to please conclude the session with a few words. Thank you.
Thank you.
Greetings to everyone who are present here globally. I thank Sir for giving us his valuable time today and for sharing his knowledge and enhancing our knowledge and skills today. Thank you so much, sir. It's our honor and privilege having you here today. So it's very kind of you. You are inspiring, and sir, we are very thankful to you for being with us today. Thank you so much, sir.
Anmol, thank you very much for the opportunity. Everybody have a wonderful day, and I appreciate this opportunity. Take care, and
Thank you.
be careful with your resorption. Bye-bye now.
Bye, sir.